personal. It's everybody.
Okay, welcome, ladies and gentlemen. We'd like to call to order the meeting of the Rutherford County Risk Management Committee. And the first item on the agenda is to approve the minutes of the last meeting. Do we have a motion?
Motion to approve.
Ms. Hickerson and Mr. Hafner. Anyone have any corrections or additions they'd like to make? If not, all of you in favor of that, please say aye. Are there any opposed? All right, thank you. Mrs. Street, give us a report on Funds 264 and 266.
Good afternoon. I would like to tell the committee before we begin, there was an adjustment to the agenda this month. That will go on to next month's agenda, as well as the property and casualty renewal. So I would encourage you to eat lunch and to block off a good bit of time on your calendar for next month's meeting, because we'll have quite a bit to cover in that meeting. So we'll begin with Fund 264, reporting on the month of January.
Yes, sir.
The revenue for the month of January is $6,614,506, with expenses coming in at $6,054,827. The difference by month on revenue is $559,679, and the calendar fiscal year difference is $946,142. Continuing on to page 2 of the report. This compares calendar period year-to-date revenue versus expenses. When you look at prior period revenue, we're at $6,055,793. Compared to current, we are at $6,614,506. Expenses in prior period year-to-date was at $5,960,616, compared to current year expenses of $6,054,827. Fiscal period year-to-date revenue on prior period came in at $32,436,080, compared to current of $34,113,851. The expenses on prior period year-to-date came in at $39,850,093, compared to current of $39,182,980. On the last page of the report, you'll see the information I've just shared repeated in the second column, which is the 2018 calendar year revenue versus expenses, and also the information is repeated on the 2017-18 fiscal year comparison as well on this. Monthly enrollment in the month of January was 5,981 employees, and you'll also note that on the last page, the net OPEB has been added as of June the 30th, 2016.
Okay, questions for Mrs. Stinson regarding this report? She's not quite through.
All right, so we can continue on with Fund 266. In the month of January, year-to-date, we came in at $553,683, compared to prior period of $408,096. Now we're finished. And no vote.
All right, so Mrs. Stinson, give me your assessment of how we're doing this year compared to last year.
Well, from a calendar year perspective, it's too early for us to tell how we'll continue throughout the end of the year. We feel comfortable with the rates that were set, that they will hold throughout 2018. We do see on a fiscal year comparison that right now the difference in revenues and expenditures has expenditures higher at $5 million, and we have a few more months left in the fiscal year that we expect to bring that number down throughout the remainder of the period. But we do see that we could have a shortfall in this current fiscal year period.
The previous fiscal year, there was a $1.7 million shortfall. Am I reading that correctly?
So in the current fiscal, yes, it did come in with the expenditures at $67,015,595, with the revenues coming in at $65,283,928. So from a fiscal year perspective, it did have a shortfall of $1.7 million. Now, when we do set rates, we look at it on a calendar year perspective. Deductibles, co-pays, out-of-pocket expenses, any changes with the insurance plan are effective on January the 1st. And so rates are based on a January 1 to December 31st time frame annually. So the number that we would be most concerned with from a budget perspective in terms of how we look at it from insurance, which is different than how finance looks at the world, would be that shortfall of $946,141.
Okay, now, questions. Ms. Nolan.
I would just make a point that when you look at her revenues to expenses for prior year, at this point, we were down $7 million. So we're really not as bad as what we were last year at this time. So right now, we're
Okay.
down 5, but last year we were down 7, and we came in
This year we're down. Well, this year we're down 5. Is that right?
Right, at this point, we're down 5, so.
We're a little better than.
Well, all things being the same, Ms. Nolan's point is that we should end up in a positive at the end of the period.
Staying the same, then
Right.
we'd end up
Positive.
Kind of-
They're flat.
flat.
Well, that's what I was hoping you were going to tell us. We're making some improvements this year.
So we recognize the shortfall in the, when you set premiums, one of the challenges that we have is the fact that we use through January 31st data of prior year to set rates for the upcoming year. So there's 11 months of experience in there, which we have not accrued to get us tighter in terms of what our experience will show over that year. So for an organization, we really do set rates very far in advance, but that's because of our budget process and our fiscal year being July 1. So whenever we look at premium rates, as an example, right now we are looking at 2019 rates. We're using data from February 1st, 2017 through January 31st, 2018 to set rates for January 1st, 2019. So there is a lot of time difference in terms of what our experience is and when we are setting the rates that can have an impact on what you see in your financials. The other thing too that affects it is enrollment. You have to project what you expect your enrollment to look like, what plans people will go into during the next annual enrollment period, and what that will look like on January the 1st. So there are a lot of factors that have to be reviewed whenever you're setting the rates.
Mr. Sandvig.
Kind of a bit of explanation for some of the newer members on here. When we're talking about this deficit that we start the fiscal year off, July and August, Board of Ed premiums for the summer are prepaid. So there is no revenue, no insurance premiums from the employer or the employee coming in for all the Board of Ed employees July and August. So that's why we start off negative every year, but it should correct itself.
All right, so in regards to the prepayment of premiums each month, because we collect premiums on a 10-month basis for all Board of Education employees, they pay premium from September through June. And so all of the premium has been booked in prior fiscal year, but yet we are paying claims in the current fiscal year in July and August for which we have not collected premium for from the Board of Education. So we do have that offset there to his point. Now, eventually it will flush because this year we'll collect premium in May and June to help offset the 2018 July and August claims. But that's why you'll see the trend line be what it is for a period of time.
Okay, any other discussion or questions? Okay, so we're ready to move on to workers' comp and OJI stats. Mr. Good.
Good afternoon. I'd like to report in the month of January that we had a total of 21 injuries requiring medical attention. Since January is the first calendar month for the OSHA calendar year, that's also how many injuries we've had for year to date. Of those injuries, 15 of them were OSHA recordables, 6 were restricted days, 4 were lost time days, and 5 were all others. On the next page of your report, you'll see how this January compares to the 2 previous years, and we are up slightly, and that's probably expected because of the employment of the county has been increasing. On the 3rd page of your report, you'll see the incurred dollars. In the month of January, we did have 1 injury that elevated the lost or the incurred dollars at this time. Again, those are just estimates as incurred dollars. We don't know those. Those dollars will take a while to settle down. Usually they do come down, but essentially 1 injury on slip, trip, and fall involving the weather that we had in the month of January in the snow. The incurred dollars for the month of January was $146,000. And the way that breaks down in the injuries, 13 of them were in the Board of Education, and the total incurred dollars there were $13,050. The county general had the other 8, and that's also where the slip and fall occurred. And the total incurred dollars there was $132,997. And the last page of your report breaks that down by the different departments within the county general. Are there any questions?
Did that injury occur during the voting process, or was it just at the election commission building?
I'm sorry, I didn't understand. Well, that injury occurred, it actually did not happen on county property. It happened on city property, but it happened to a county employee. So what we're looking at, of course, is the county's responsible to take care of the employee as far as the work-related injury, but we will try and go back and segregate that against the city, since it was on city property where the slip and fall occurred.
This during the election period?
Early election, yes, sir.
Okay, the special election?
Yes.
Okay, that was an expensive election.
Thank you very much.
Thank you, sir. Okay. Well, all right, Mr. Puckett, are you ready to give us a wellness update, please?
Good afternoon. Quick wellness update for you guys. We kicked off the Know Your Numbers campaign for 2018. You can see right as of now, or as of last Friday, the reason these results are from last Friday is because our report is ran only once a week on Friday, so I won't have the updated numbers until tomorrow. But as of 2/16, year-to-date, health risk assessments are at a completion of 114. If you look between 2018 and 2017, we're up. Although it's not a lot, it's still up, so progress is progress. We'll take it. The biometrics also had a good jump, 277 from 239 in the year 2017. Another good number to look at here is both people have completed both requirements. 2018, 28, up from 5 last year. So I think the message is getting out, and a good thing to take away from that, even though, again, these numbers are small, we're still moving the needle in the right direction. So our promotional efforts are indeed paying off, and this year we didn't do any incentive. Last year we incentivized the people to participate with iPads and a few other goodies, and we did not do that this year because we didn't see the need on spending that money, and the numbers are still up. So we're doing something right, we're excited about it. And in November, we had went over some stats from the wellness fair. You all had asked for some specifics on some of the testing that we did. We do have some results from the angio screens. Now, keep in mind, an angio screen is just a non-diagnostic vascular view of your arteries to kind of look and determine your risk for heart attack and stroke. Some of the good results we had, 0 of the 26 participants with an average age of 50 had signs of peripheral artery disease. Now, peripheral artery disease is a narrowing of those arteries that are in your legs that feed blood to your lower extremities. So there was no sign of disease there, which was good. 0 had signs of a normal heart rhythm, also AFib, irregular heartbeat, heart skips beats, stuff like that. And then 0 had signs of normal blood velocity. Basically what that means is the speed of blood that's moving through the arteries. Everything was good there as well. 16 of the 26 participants had either stage 1 or stage 2 hypertension. Obviously, that's something that stood out to us. And as I mentioned on the last meeting, what we're trying to do this year is target some lifestyle management classes around how to deal with hypertension, diabetes, how to eat right if you have hypertension to lower those numbers. So that is something that we're going to take away again and then probably hopefully promote that to get those numbers down next year. 19 were either overweight or obese. I will say, take those results with a grain of salt. They use the BMI scale for that. That scale is kind of flawed. It doesn't take into consideration lean body tissue or something. So if you have somebody who works out a lot, like a football player, they may have a BMI of 35, so they're considered obese, but they have 6% body fat. So some of those numbers are probably accurate, but it's just a generic kind of tool used to scale that stuff. So, obviously we'd like that number to be down, but it's something that's on a case-by-case basis. And the last thing, 4 people had plaque buildup in their carotid arteries. Those are the main 2 arteries on the side of your neck that take oxygenated blood to your brain. So overall, looking at the stuff, I think some good, some bad, some things we need to work on, but from a health promotion strategy, it helps us kind of build our promotion strategy in 2018 around some of these numbers. And I will say too, there was a big demand for angio screens at the wellness fair. We only paid for 26, so what we're going to do is we're looking into doing some research on how can we bring angio screen back into the county, maybe in the spring or early summer. The things that we're kind of researching now is the cost related to it to us, and then also the employee. So it's something that we're researching now to see if something that we can actually do. The diabetes screening was another one. So with this one, it was a self-assessment tool. So how they did it, they ask you questions based on your weight in relation to your height, physical activity, and your family history, and you would total up the points. If you had a total of 5 points or higher, you were considered at a higher risk for type 2 diabetes. You can see here in the findings, 22 people completed the assessment. 11 of those scored higher than 5 or at 5, so about 50% of the people who participated are at a higher risk for type 2 diabetes. Now, I reached out to the lady who handled these screenings for us, asking if we could get those individuals' names so we could maybe reach out to them and say, hey, you were flagged for this, not to worry, we have tools, we have dietitian and wellness coordinator that can help you and get these issues under control. Unfortunately, because it was a self-assessment tool, they didn't capture any of their names. But hopefully we can do something that will get the entire population engaged so we can still target those people without knowing who they are. Current and upcoming activities for February, March, we are doing our first quarter weight loss program right now, Mission Slim Possible. We have 115 people registered for that. Have some good results coming in, so we'll be happy to share with you those on the next meeting. The lifestyle management class coming up on March the 15th is, it's titled Spring into Fitness, but we're really going to focus on meal planning and how we can do that made easy with our busy lives. And our wonderful dietitian back there is going to be leading that class, so hopefully you guys can come. Life Services EAP this month is about self-care, remaining resilient. That's available from February 20th to the end of the month on demand. If you look in your packet, I included the entire EAP class schedule for 2018. If you could, take that back to your respected offices and post that. There's a lot of good information out there for your employees, and all the information on how to log in is on that sheet as well. Any questions on that? Yes, ma'am, absolutely. I can handle that. And last, but certainly not least, if you turn to the flyer that says your baby isn't the only reward. Oh, sorry, go ahead.
I'm just curious, because blood pressure ranges have changed. What numbers are you using?
So Stage 1 hypertension is considered anything 130 to 139 over 80 to 89. And anything stage 2 is 140 or greater, or anything over 90 or greater. So 140 or 90 or greater is considered stage 2.
And one other thing, I just heard this on talk radio like 2 days ago, that there's a study that older individuals, if they're 5, being thin is not good. Having 5% over what your normal weight range should be. Do you know anything about that study, that it's healthier for you to be about 5% overweight?
I have not heard that.
So basically, I just need to wait to get older and I'll be fine. That was good news for me.
So for that study, they did have a study that came out and it showed that being 5% over was a protective factor for certain chronic diseases. It can be protective in certain chronic diseases, however, puts you at risk of others. So it's still not a fully tested study. It is one case where they did see some results from that. So I would like to see further experimentation with that and see where it goes. But as of right now, that is, I saw that study as well.
Well, we know everything that's on the talk shows is all accurate too, right? Social media, no problems. Okay.
And so this thing here, as we mentioned in November, we're going to start talking about, we're going to highlight a program each month that is offered to Rutherford County employees and their spouses. This month is the Healthy Pregnancies, Healthy Babies. This is a great program. It's for anyone expecting. Basically what it is a personalized maternity support program. You get a nurse that will talk to you. They're available 24/7 through our nurse information line. Let's say if you're having a certain amount of pain. Now, granted, I don't know too much about pregnancy, but if you are in a certain amount of pain or have questions about what's going on at certain times, you can call that nurse 24 hours a day, and they will be able to support you. One of the biggest things is this is one of the programs, and I believe one of the only programs that we offer that is incentivized via Motivate Me. So what happens is if you register for the program in the first trimester, you'll get a $150 gift card once you complete the program. If you do it in the second trimester, you'll get a $75 gift card. So there's some incentive there. If you do it in the third trimester, you will still go through the program, but you won't get any incentive for doing it. Right now, this is just available for employees and spouses. Dependents on the medical plan can participate, but they're not eligible to receive an incentive. And I will say, last year we made a conscious effort for the first time to promote this more, so we sent out a mailer to anybody any female on the county plan between the ages of 18 to 45 to try to, hey, this is something that you can do, you can earn an incentive, it's very beneficial. We saw, because we did that, and that was Director Street's idea, we saw a jump. We doubled our participation from 28 to, I believe, or excuse me, 28 to 40, so we almost doubled. We increased it by 20 last year, and we just sent out our mailer this year to do the same thing, so we'll hope that number will increase again next year. So last year we had 153 pregnancies, and of those 153, we had 48 participate. So somewhere around like 30-something%. Obviously, we'd like that number to be higher, so we're making the effort to get it higher. Any questions? Oh, and one last thing. I did send this information out in an email to everyone in the county, I believe about 2 weeks ago. So hopefully you guys all got it, and then send it out to your employees as well. So, any questions?
Well, thank you then, Mr. Puckett. We
Thank you.
appreciate that. Midpoint report, Shannon McNair.
So this is something new for the committee that we'll be including monthly. In our prior financial reporting, we included specific information about the clinics. That is now combined in the financial numbers. So I asked Ms. McNair to go in and specifically design a report so that it could be used as an educational component for the committee, so you can understand the value and utilization of our MedPoint clinics, which are our 3 employee health clinics that we have throughout the county, as well as the retail locations. And so, Ms. McNair, if you'd like to go ahead and start your report.
Good afternoon, everyone. If you want to go ahead and open your report to the first slide titled Clinic Visits. As you see there, there's a yearly trend for last year, 2017, January to December, with our monthly visits, and it's also detailed at the bottom. And I know we haven't had a meeting in a couple of months, so I'm going to go back and look at November's numbers. We had 2,011 visits November of 2017. We had 2,405 visits in December of 2017. And if you look at the second line down there in the red, January last month, we saw 1,544 visits. Now, if you compare January of this year to January last year, you'll see a little bit of a drop of about 150 visits there in the 3 clinics. We did have some clinic closures due to the inclement weather we saw there at the clinic and some abbreviated days, so we think that that is a direct reflection of that decrease in those numbers. Any questions? And I'm sorry, there is a year-to-date average at the top for 2017 of 2,292 visits per month.
One thing that I would add in her comment about the adverse weather that we had in the clinics, Premise Health has contracted out because the schools will close during that time, and the exterior of the schools where our clinics are located are managed by the custodians there. So when the schools are closed, there's not a custodian to assist us with removal of ice and things like that. So as a safety measure, they have contracted with someone locally who actually goes out to the schools where our clinics are located and clears a path so that we can have safe utilization of our MedPoint clinics during adverse weather conditions.
Okay, we're going to go to the next slide, which is our visits at the Walgreens clinic. It's our retail clinics that we have. You'll see the trend there at the top, the little graph, and in the blue, obviously, is our 2017 dates and visits to the retail clinics at Walgreens. And November, we had 81 visits at the retail clinics. You'll see a pretty large spike there in December of 270, and as you all probably are very familiar with, we've seen a lot of flu and strep in the last couple of months in the county. So we think that's the big reason for the increase in December, as well as 205 January of 2018. Year-to-date average for 2017 was 138 visits per month.
Ms. McNair, back to those clinic visits. I guess it should be obvious. What's happening in, August and September? August and September.
Yes, sir. So August and September, you all know that our biometric deadline is September 30th every year, so we do see a large incline. We do about 2,500 extra visits for biometric screenings in those 2 months of August and September. So even October may be slightly higher because a lot of people are getting those results and are coming back to the clinic to review those with the provider. So we do have the increased visits in those 3 months.
Thank you.
The next slide, we're just going to go over our wellness visits. On the left there, you'll see our wellness coordinator visits. In November, she saw 40 visits. That's 36 follow-ups with 4 initial visits. December, she saw 25 visits, and that's 20 follow-ups with 5 initial visits. And in January, she saw 45 visits, and that's 36 follow-ups with 9 new patient initial visits. On the right side of your page there, you see our registered dietitian we have on staff and her visits. November, she saw 21 visits with 17 follow-ups and 4 initial visits. December, 14 visits with 11 follow-ups and 3 initial visits. And in January, 13 visits with 9 follow-ups and 4 initial visits. On the next slide, we're going to move to the per employee per month summary. It's kind of a summary of the office visits, the retail visits, the total operating cost for our 3 clinics, including the cost for those retail visits. And then we break it out to average or cost per visit and per employee per month. So if you look at January 2018 there at the top, we had 1,544 office visits, 205 retail visits at the Walgreens clinic, with total operating costs at $234,591. Averages out to be cost per visit $134 per visit. We use the eligible lives gotten from Ms. Street's office, and so per employee per month, that averaged out to be $39. And if you will turn to look at the last slide, so this is a slide that I will include every quarter for you guys to look at and review. This is just a quick snapshot of our quarterly savings that we bring to the table. If you look at Q4, it was $293,152. Now, how we determine our quarterly savings, we look at a couple of different things: direct cost avoidance, whether, we look at procedure codes and what it costs for us to deliver that care versus going out into the community and getting that care. We include if normally it's a diagnosis that would be handled by a specialist, but that we're able to manage that care appropriately in the clinic, then we include those in those cost savings that we're providing, as well as emergency care. So if you have a patient that came to us that normally would go to an ER to be treated, and we're able to treat that in-house safely and effectively, then we include that also in these quarterly savings. So that's how several factors play a role in how we get those quarterly savings, but that's some of the ways, or some of the totals that we add up to get those for you guys. So total year-to-date savings for 2017 was $1,781,228 for the whole year.
Okay, help me out just a little bit more there. I mean, I'm sure all of these members here understand. This $1.7 million, is that in cost avoidance or preventative measures that have been taken that we would have incurred these other costs had you not been servicing these people? Is that what you told us or not?
So direct cost avoidance, so, if it costs the per visit, $136 to come and see us versus what it would cost to go out into the community to see and treat that patient. It includes specialist referrals that a patient may go see a specialist for this, but we're able to manage it in-house, as well as productivity, like time off from work, things like that. So all of that is included when we determine that quarterly savings.
So one of the things that we do, and right now it's come up for review again as an example, is I will work with Ms. Stevenson or someone in the finance office to come up with our average hourly rate for our population, and that will be one of the calculation basis in which she looks at lost time savings and things of that nature included in it.
And our people are healthier overall. So, I mean, all of this is to everyone's benefit, right? It appears.
One of the things that I will, in terms of relativity of the information being provided to you, if you'll go back and look at page 5, which is your PEPM summary, it also gives you that cost per visit. Mr. Huffman will be coming up and providing a snapshot of our consultative analytics annual report that I have received from them. And in it, you'll see that in a private sector physician market, we're running about $160 per visit, whereas you can see the cost per visit inside of our clinics, and that includes all overhead, operational expenses, supplies, and generic medications included in that. So it does demonstrate the efficiency of our clinics, and the fact that our utilization remains high at our clinics shows that they are producing service to the employees that have them returning. And in a lot of instances, we are the primary care for our employee population, and they wouldn't receive that care otherwise. We have seen an increase in new employees, or new in terms of first-time users into MedPoint as a result of our biometric efforts that we put in place, and that has helped us to reach out and touch base with employees that we wouldn't have otherwise had an opportunity to. So they do a good job managing and running our clinics, and I appreciate the job that Ms. McNair does out there.
And Ms. McNair, do you people ask your clients to evaluate you in some particular way from time to time?
They ask me straight quite often, actually.
So what they have implemented recently is a per visit survey. It's a 3-question survey, so every time someone leaves, they get a chance to answer the survey. I laughed yesterday, we had a meeting, and I told Shannon they had the right to refuse to complete it, and I told her that I had gone in last week and refused. I just couldn't in good conscience answer it, so I was like, I better abstain from answering it. But I watched people come out after receiving service, and they were glad to answer it. So that will give them kind of point in time response and feedback. And then annually they use Sullivan Llewellyn to do a survey as well. So they'll continue both of those efforts. But to Ms. McNair's point, we have a very vocal population, and they will let me know or Ms. McNair know whenever there is a concern, and we always appreciate that, and she's very good about following up and getting back with them and bringing it to resolution. So.
Okay, that's a good report.
have a question.
Ms. Allen?
On the quarterly savings, when you're calculating that, are you using what a full retail price would be, or are you using what our contracted rates would be had they gone to their physician?
It's contracted rates. So just like when we pass the claims over to Cigna, just so that we can, for data collection only, we utilize what their provider network discount would have been to value out what that claim looks like. So it's the same approach.
Ms. Stevenson?
Just from my understanding too, is on the page 5, where you do the per employee per month and you come up with that rate, just from my understanding, why would you use the cost per employee per month for the total population as opposed to just the people who utilize the service?
So I use this report to mimic what you guys have seen in the past and just to keep it standard. So I know that there was a time where you guys didn't see this anymore, but to stay with continual what you guys have seen in the past.
So per employee per month is just that, it's per employee per month, not per utilizer per month. So if we did it per utilizer, then it would include dependents as well. So we'd be counting how many belly buttons have come through there, and we would get to that per participant per month figure. Typically, when we look at what is the value of our benefits that we offer employees, we're looking at it from an employee perspective. We can divide it, however, if it seems more meaningful to the committee, though, to see per participant per month. I think that number, just like with employee per month, is going to vary because it's going to depend on what conditions you had, what number of prescriptions were given that day. In January, that number would jump because they have just been inundated with the flu and upper respiratory and all of that. So the prescription count's higher this month than what you would see in July, as an example.
I was just curious. I mean, I know that you've already got it calculated out, the cost per visit, which would be the average over all the employees who utilize the service.
Right.
But I was just wondering, like, how that was meaningful, in, to understand it. And then another question to follow up on what Ms. Allen just said. So, does the amount that you use to do your year-to-date savings, does that include, and she may have already asked it and I'm asking it again, but do you bill the insurance, and is that the amount on top? Because when they go to the clinic, they're not billing insurance at all, or they are billing insurance?
We're sending it over for data purposes only. We do not receive any funds from Cigna. We do not bill the insurance and receive any money in return. We're contracted with the county to provide that service, and that's our operating costs are all we receive for that. We do not bill the insurance for any other reason than data purposes, so they have that information.
To your point, though, Ms. Stevenson, because I understand kind of where you're going with this, so like ER avoidance is one of those. So, and correct me if I'm wrong, they'll look at what their utilization has been in the prior month, or in the month in which they're reporting, and say these are the conditions which could have resulted in a trip to the ER had this service not been available, and apply a calculating factor on that. So that's where the ER avoidance comes in. Is that correct? Yeah.
Oh, and I was kind of looking at, like, if I went to the doctor for a sinus infection, say, my bill post-insurance might be $50, but the insurance might have paid $100.
Right.
So, my offset cost would be different than what the total cost would be. So that's what I was trying to figure out in my mind, is it the total cost of the service or post-insurance, pre-insurance, or whatever cost. So what you're telling me is the cost, the flat cost across the board.
So one of the things that we can do, and we bring to you what we think that you will want to see, and then we listen to your feedback and we modify. I think what would be helpful next month from the cost avoidance perspective is actually bring those categories that's in the more complete report and let them see that and explain what the basis of the calculations are to further expand on this particular
Like from the
category
QR.
for 'em.
Okay.
Yeah.
Yes,
So we
ma'am.
can do that. Yeah.
I was just going to say that when we look at the whole plan, we don't look at all the people who went to the doctor in the whole plan. We always get it back down to how much per employee per month.
And some of the calculations that Mr. Huffman will show, you'll see that per member per year calculation, but the one that we pay the most attention to is that per employee. Now, where we do start really paying attention is what is our employee cost versus spouse cost versus children's cost. And we'll talk a little bit more about that when we look at the dependent audit piece.
Any other questions? Okay, thank you for that good report. Mr. Huffman? Client analytics. Now,
good afternoon. In front of you, you have a 13-page package that looks like this. And this is a brief summary of probably a 100-page package that we meet with Ms. Street every November, and we review the previous policy year. So we spend probably a couple hours, 2 to 3 hours going through this, and I'll try to summarize that as quick as I can with these slides that we've decided to look at. Just as a basis or background of what this report represents, if you look at the bottom left of the cover sheet, you'll see this is going to reflect the medical and pharmacy claims for your active population. So we've removed the retirees from the group. When you see the term base period, that's 2 years ago. So that's July 15 through the end of June 16. And then the current period is going to be your last policy year, July 16 through the end of June 2017. So we're a few months from there, but that's the report package, and we look at it on an incurred basis, so when the service date occurs and falls into that period. Where you see the word norm, that stands for normative, and that's a comparison to our entire Cigna book of business for public sector accounts that we have. So we're going to be comparing you to like industries, municipalities, and government accounts that we have. Where you see catastrophic threshold, we're going to remove claims or identify catastrophic claimants that have claims over $100,000 per person. And so we'll turn to page 2, and like I said, we'll go through, I'll pull just maybe a highlight or two from each page. This first page 2 is an executive summary that kind of hits on the entire utilization. Keep in mind, when we do this, our goal is to look at trends. So we use that as a term of increase year over year, and then we break it down under medical, pharmacy, then we break medical down into inpatient, outpatient, professional. We break pharmacy down into retail, home delivery, specialty drugs, specialty pharmacy, specialty medical. So some of those details I'll try to highlight, but this page gives you kind of an overview. In the top right corner, under medical and RX trend, pharmacy trend, as Ms. Street indicated, where you see PMPY, that refers to per member per year. So we're looking at every person, every body that we cover, every dependent, spouse, and employee is considered a member for this report. And then we average that out to a total dollar amount per year. If you look at the current per member per year, you'll see that the total plan spend during that past policy year was about $5,314. A very good story here is that is only a 1.3% increase or trend over the same period the year before. And that is a 13.7% lower than our normative for industries of yours. Moving down that chart, the medical plan spend, so if we break that total cost out into medical only, we're looking at $4,100 total spend for medical, and there was less than 1% trend year over year. So we are managing costs and managing trend regardless of the inflation that we see in the market for costs. A lot of the health activities that you're hearing, the usage of the clinics is controlling costs, keeping people healthy, keep them out of the hospital, get them the tools they need to manage their chronic conditions, things like that, try to avoid those claims. Moving down the chart, pharmacy spend per member per year. On average is about $1,206 per member per year. And this is very unusual, is that the pharmacy increase was only 3% over the previous year, and we're typically seeing pharmacy trends in the 7 to 8 to 9% range each year for most of our clients. Just to highlight, if you were interested, the top left bar chart represents how we break out a dollar. So your members are picking up approximately 12% of the total medical cost. So the total medical cost is about 10% of that, or roughly $498 per member per year on average, paid for out of the member's pocket. Moving down to the right side of the page, I'm going to tease out just a little bit. Your chronic percent of population, these are the individuals that have a chronic condition, diabetes, heart failure, asthma, chronic obstructive pulmonary disease, things of that nature. During the current period, about 38% of your population has a chronic condition, and they are responsible for approximately 74% of your total cost. So this is a big focus of ours as a health services company, is that we want to engage these individuals with coaching and wellness and tools so that they can manage these chronic conditions and lower those costs. Preventive care utilization, and again, this is for all members in the plan. We saw about 53% utilize some type of preventive care service. And as you can see, that is above our norm. However, we would not want the norm to be our goal. We would want the goal to be 100%. But you are above the norm. You're doing a good job, but we do see opportunity here in the preventive care category. Well visits, kind of part of that. That's your annual physicals, about 46% completions. As you've heard before, for all individuals eligible to take the health assessment, we're seeing close to 70% completion on that. The pharmacy section below, we had an increase in generic dispensing. So anytime you increase generic dispensing by 1%, you're going to save tremendously on your pharmacy cost. And we're also seeing that the prescriptions per member per year stayed relatively the same. So we're not seeing a huge increase in utilization of pharmacy prescriptions being prescribed. Okay, page 3. This is the pharmacy benefit executive summary. A lot of numbers on this page. I'll point out just a couple of things. In the top left bar chart, out of the entire pharmacy plan spend, which is about $1,206 per member per year, your members are only picking up about 10% of that through their co-pays or their co-insurance or their deductibles. Okay, so for every dollar spent in pharmacy, your members are paying about 10 cents of that. If you look at the bottom, we break out the trend. Remember I told you that pharmacy trend was about 3% year over year? Well, part of the reason that is mitigated is due to the drug mix. Cigna is doing a lot of formulary management. Some of you may have been impacted by that. We look at our formulary twice a year, for January 1 and for July 1st, and we decide if there are egregiously priced drugs, drugs that are extremely expensive, drugs that have had huge cost increases without any improvements in efficacy, and there's other drugs that are just as good and available. We may make the decision to remove that drug from the formulary and exclude it so as to keep that cost down. That has helped the drug mix, which has been a 2.7% reduction, so we've seen lower priced medications being chosen. And then the utilization, as I said before, is not increasing. So had those things not occurred, your trend would have been closer to 5.4%.
So, Mr. Huffman, let me ask you a question. Is it fair to say then, you mentioned on the prior page that our medical member paid is at 12%, and you're saying our pharmacy paid is at 10%, so on average they're at 20% out of pocket?
No, a blend of that. So it would be, 11.
Okay.
Yeah. Okay, so page 4. This is a demographic summary, and as you can see on most of these numbers, your demographic, age, employee population by gender stayed relatively the same, and you can see how that compares to the normative. Two things I'll point out is in the age band, we are seeing still, as we know, a significantly high average per member per year for the older age bands in the 60 to 64 range and the 65 plus range. Not only are those age bands expensive, they are also above our normative, and they are also trending at an exceptionally high rate. So it is a group of a population that we're aware of that is at high risk. They have a lot of the chronic conditions that I mentioned. A lot of them end up being catastrophic claimants. So I wanted to point that out. So even when you exclude the catastrophic, so those over $100,000, you can see the numbers come down a little bit, but even in the 60 to 64 range, we're still seeing a 13% trend in that population.
So I want to pause there for just a minute, because that is relevant to the conversation that we will have next month as it relates to insurance rates. If you recall, 2 years ago, we blended the rates of that population of pre-65s into the active rates. It caused $1.5 million increase to the active rate base first year. It cost $1 million second year. So this number of the 60 to 64 age group is significant to us in that it is driving some of our rate increase that we see for our active population as we set those rates year over year. If you will look at it, going back to some of the other reporting that we've seen, our average age falls into that, of employee falls into that 40 to 49 year group. And their cost, excluding catastrophic, which is claims over $100,000, runs on average in current period of $5,040. When you look at that 60 to 64, they are running $9,910. And including catastrophics, we have a comparison of $6,300 to $14,500. So it is a significant, it's a very small population. It's roughly 150 people, I believe, but the amount of claims they incur per member is significant.
Got a question?
Yes, sir.
I'm going to wait till the end, but since Melissa started talking about it, on your comparative population, the normatives, does that exclude all of the retirees in the population? Because you see a big jump every time you add a comparison to the norm.
Yeah, it does.
Including the retirees.
No, it's a good question. So keep in mind, we've removed your retirees. Yeah, and so the normative is also 65 and under. 60, our normative, I will caveat, the normative is based on an age, so it won't differentiate retired or active. It could be. Could have some, yeah. There could be. It's close because, like I said, the only thing difference is that you could have some of the, no, it would be because we've removed your retirees. Okay, so you've got active. Possibly, but they're still under 65. Could be.
They're still on a blended rate basis, so for
Right.
the purpose of rates,
The way we have your structure broken out would not be able to run the report that way.
so for this
we have-
report, it's that way. When we
Yeah.
get to the rate discussion report,
Yeah.
those claims do come in divided between what our retirees are doing versus what our active population is doing. And then the data is then blended to come up with the average rate that we need to cover both of those entities.
It just makes me have trouble thinking our comparison to the norm is good when we really don't know what the norm consists of.
Your norm here is, your comparison to the norm here is actually very bad.
Well, I mean, okay, then it's worse.
Yes.
I want to make sure, if I'm seeing, I think I see where he's going with this. If we're on the same page, say page 4, top left-hand diagram, right? I understood you earlier that the normative on the front page when you were explaining it, the normative is based on your book of business.
Correct. Correct.
Okay, so the norm will be the book of business.
65 and under 65.
Right.
Public sector.
Okay, so your book of business under the 65. So your norm is showing your book of business is higher than Rutherford County's base and current, right? Is that what I'm seeing? Am I understanding that correctly?
Under which age band?
Okay. Okay, we'll just say 50 to 59, okay?
50 to 59, you're below.
Right,
Yeah.
so we're below the norm. If 60 to 64, we're below.
No, you're higher.
No, the norm column is higher than our base and our current, correct?
No. Norm is 9,500, and your norm is 14,000.
Say that again. I'm looking just at the bar chart. I'm only looking at your bar graph, is all I'm looking at. I'm not looking at the,
bar
To the
graph-
top right, top right.
The bar graph is the percentage of membership by age band.
Correct.
okay?
It's
so
not
we're still sa-
dollars.
It's still saying the same thing, because
No.
the normative in the
No.
60 to 64,
Those are percentages on the left, on the right is dollars. Okay, so the top right is what I'm looking at. Okay?
so the top right metric is percentage of dollars, not percentage of age.
Bottom left is percentage of plan spend. I'm looking at the top right, and I'm comparing the average per member per year for your 60 to 64. You're averaging about close to $14,000 per person, which is higher than our norm at $9,500.
Ms. Stevenson,
Okay.
are you looking at the gray line
Yes.
and how it extends up?
Yeah, I'm looking at the graph in the top left-hand corner. For 60 to 64, the normative for Cigna's book of business is higher than the county's base and current trend for 60 to 64 per this graph.
Your percent of plan spend by age band in our book of business would have a higher percentage in those categories than you do. You have less members than others in our book of business in those categories.
I think I see where, okay.
Okay.
I think I see where it is now, just.
That's because you have
the-
less.
The age range is, your book of business is higher for that age, but our spend is higher than your book of business for the same age spend.
Per person, correct.
Per member,
Okay,
per
okay.
member.
Thank you.
Correct.
Mr. Sandvig, you got that straightened out now?
One other number, not to delay going forward, but one other number I just want you guys to kind of see and hold on to is the average spend by relationship, excluding catastrophic on the spouse on current. You'll see the number of 6,688, and we'll use that number again in the dependent audit results to date. So I just want to point out that that's where that number will be pulling from.
Thank you. All right, so page 5. A pretty good story here, too. I think we don't always have this story to tell, but as far as catastrophic claimants go, we had almost the exact number of those individuals over $100,000 from the base year to the current year, 54 versus 52. And that is below the normative, so we're seeing just a slightly fewer of them than our book of business. The average cost per claimant is still pretty high. It's at around $216,000, but that's relatively close to where we were last year. The interesting thing is in the top right, you'll see that the only thing that trended high for those catastrophic claimants was the outpatient spend, and that's actually good. We'll see at the bottom, the reason for that is we have several neoplasms, or an increase of neoplasms and cancers, so you've got some infusions going on, drugs that are being infused for those conditions. Circulatory dropped by 6 high claimants, and we did see about 8 additional musculoskeletal large claimants. Moving on to page 6.
Mr. Huffman, just kind of highlight on the report that Mr. Puckett did. The newborns here in the base, we have 1 catastrophic individual count, and then on the current, we had the 1 catastrophic continuing for the current period as well. We are seeing that stabilize. In years past, we've had multiples that have driven some of the costs from a neonatal perspective as well. Is that correct?
Correct, and we're seeing that across our book of business too. That is a big issue with a lot of our clients, is the premature newborns. And later in here, I do have a slide that corresponds with what Daniel presented to you with regards to healthy pregnancy, healthy babies, so and how that impacted. But yes, you've got a very good result here as far as only having 1. We'd rather that be 0, but it could be a lot worse. We've seen premature births run in the $1 million range per birth. Some are twins, so you're looking at $2 million for 1 set of twins. Page 6. This is your top drugs by spend under your pharmacy benefit. And this, as you can see in the base period, you'll see where the drug previously ranked the previous year and what it's ranking this year. and how those drugs either stay the same as your usual suspects or if they have increased and jumped up the list. We've highlighted about 4 of these that are red in the diabetes condition, and this goes with the formulary management that I spoke to you about. We have seen some large increases in these brands and have removed them from the formulary, so we'll see these drugs fall back off of the list because we anticipated or seeing them move up the list in cost. We know there are in the same class of condition, there are drugs that treat the illness the exact same way, and we allow those as alternatives. And page 7 gives you just a quick look at specialty pharmacy. Specialty pharmacy is where a lot of our pharmacy spend is these days, and the pipeline of drugs that are being reviewed to be approved is astronomical. The cost of these drugs typically is over $500 a script. Many times we're seeing $30,000 a month come through for certain kinds of infusions. And the good news here is that your total specialty pharmacy trend year over year was only 5.6%. And we're not seeing much difference in each category. In fact, under the medical benefit, so the medical plan covers some specialty drugs through like infusions, home infusions, infusions in the office and things of that nature. The ones that were done in outpatient or inpatient setting in the hospital, we saw a significant decrease, and that's our goal. So Cigna is actually reaching out to members who are receiving infusions in a hospital, a very expensive setting, and we're talking to them and their doctor about moving those infusions either into the doctor's office or into the patient's home, which is actually more convenient for them and much less costly. So we're seeing some improvements there that has kept your specialty pharmacy trend exceptionally low. Mm-hmm. Yes.
Before we move too much further on, I realize that we take some of the prescriptions off briefly, don't have to go to it a whole lot. But we've removed 4 diabetic condition drugs, okay? And what gets them off the list? Because in looking at this list, I'm like, okay, we're getting rid of diabetics, but we're covering other things. So what and who decides what drugs come off the list? Because I personally know across the board, other counties or employees and everything, some of the diabetic stuff affected some people I know. So I'm just curious as to how did we come to this, and then how does some other drugs stay on?
Yeah, it is a committee, so we have medical directors and pharmacists that are board certified reviewing the list every 6 months to decide what is the best drug efficacy and cost. So we're looking at both cost and efficacy. So if a drug is expensive, that doesn't mean it's being dropped off the list. If it's the only drug that does its job, it's staying. We've got to have it. These are drugs where there is an alternative that does the exact same thing and manages the condition in the exact same way. Okay. The second thing to remember, keep in mind, anytime we remove a drug from a formulary and an individual has a condition that requires them, or they've tested these other drugs and they have found through their doctor clinical evidence that they have to take that prescription, they will be approved for it. So even though it's being excluded, if a clinician says, my patient has taken these 2 or 3 drugs in the past, they don't work for them, I'd like to request an approval, it will be approved. Okay. Yeah. Okay, good.
One of the other things too, Mr. Huffman, is whenever something becomes generic, is that correct? That can also change what the formulary looks like?
Well, yeah, and that happens automatically. So anytime something becomes generic and the brand moves, usually ends up becoming higher price, then the pharmacy can automatically substitute the generic when it's filled. And like I said, we saw 88% generic penetration on your group, so you're achieving best-in-class generic utilization rates. Page 8.
We'll point out just a little bit on the preventive care summary. I'll start with the preventive care percent as a of your total spend. So keep in mind, in the current year, preventive care is only 60% of your total spend for pediatric, and only 41% of your total spend in the adult range. If you move over, there is the percent of individuals continuously enrolled for the last 12 months who did not see a primary care or a specialist. So no office visit that we've seen by age. So 20% of the population we did not see an office visit from. So those are the individuals that we want to reach out to, that we want to encourage to at least get a physical, go and get a biometric screening done, and that way at an office visit. And then you can see the age bands where it typically occurs, and that's no surprise. It's in the 18 to 39 age range. We talked about cancer a little while ago, and so your cancer screening rates, we measure 3 of them: breast cancer, cervical cancer, and colon cancer. You are exceeding our normative, so you have a better result as far as your cancer screening rates on the breast and cervical. However, the colon cancer is below our norm, so we want to continue to educate individuals on these screenings. They're free. For many of them, they're supposed to be done every 2 years, and then this is measured on those that were eligible to have received them who did not. Okay, and maybe this is something we can work with the wellness team to further educate. Just to point out, inpatient. Total inpatient trend is down 5.1% negative. Again, the highest or the top conditions would be pregnancy and musculoskeletal as far as inpatient trends go. Your admissions were down, your bed days were down, so everything is moving exactly like we want. We want to move people from an inpatient setting into an outpatient setting at all costs. And moving people to the outpatient setting is on page 10. So we did see a little bit of an increase there of 12.3%, but again, that's a lower cost place of setting, so we want to see that increase as long as the inpatient is decreasing. A lot of that is driven by your neoplasms and the infusions that are done in the outpatient setting. Even though you'll see emergency room and urgent care in the top left having a slight increase year over year, you are well below what we see for the public sector as far as using emergency room and urgent care. So I think that goes to the fact that you've got your on-site clinic available that people are able to use for various conditions without going to the emergency room or the urgent care center. And let's see, last but not least, so this is your Healthy Pregnancies, Healthy Babies slide. Again, this is the incentive program that we make available to your pregnant members to call in and have an assessment done so that we can determine if they're high risk or not, and to get them the appropriate materials and education and tools so that they can manage that pregnancy all the way to term. And as Daniel said, we saw a 20 participant increase year over year, and I think that was fantastic. However, keep in mind, that's only 13.7% of the completed pregnancies during the period. So anything we can do to get that word out and get people to call in when they're pregnant, it's a free program to them, and not only is it free, but they'll receive a gift card for $150 if they call in the first trimester, or $75 if they call in during the second. Okay. So the last 2 pages, I won't go into, those are summaries. The medical snapshot just gives you a lot of the information we went over and the total dollars spent down in the bottom left, and how that breaks out under discounts, covered charges, and what the plan paid versus what was not paid by the plan, and summarizes some of the demographic information as well. So I know I went through it quickly. Any questions or comments on that? Yes.
I have one question. I actually had it earlier when Daniel spoke on the Healthy Babies program. He said that we don't include dependents in incentivizing them to participate in this.
Correct.
What's the logic behind that? Because we're going to have to pay their claims regardless, I mean, you'd think you'd want them to participate.
Right. That is actually a federal legislation that we are not able to incentivize dependence on wellness any longer due to genetic information being tracked. So in order to avoid any evidence or any seeming appearance of gathering genetic information on dependents that has to do with their health benefits, we have chosen and we've been told we cannot incentivize dependents for taking a health risk assessment, healthy babies, calling into a coach, if anything. It's under the GINA regulation, G-I-N-A.
Okay, further questions? Well, members of this committee, we've had a number of reports today. We're not operating from the seat of our pants, are we? We've got a wonderful amount of data that's evaluating everything we're doing. So, and it looks like we're trying to take advantage of that and make changes as we identify them. So I think this is a pretty impressive report and set of data that you're providing us.
Thank you very much.
The street, this was going to be a short meeting, I thought you told us.
Aren't you glad we shifted some of the agenda?
Okay, we might have been here till after 5 o'clock had you not shifted that agenda.
Maybe so.
Okay, tell us about the upcoming bid announcements.
So we released a EAP bid in January for our current EAP services with a contract effective date of June the 1st. We received 3 responses to the bid that we released. Those were from the incumbent Life Services, Optum, and ENI. You'll see on the spreadsheet that you have the current PEPM is $1.44. The proposed by Life Services was $1.38. Optum came in at $1.67, and ENI came in at $2.16. One of the requirements of our EAP vendor is that they have a dedicated site located in Rutherford County for the utilization of Rutherford County eligible participants, so that they have the same location and priority placement in counseling services. Right now, that office location is in Heritage Park. We found through the reviews that Optum had agreed that they could do that. However, there was an additional monthly fee of $6,584. ENI utilizes a provider network and did not indicate that they could do that site-specific location. One of the other things that is noteworthy on Optum and ENI is that we require Title VI to be signed as part of our bid process, and neither one of those organizations were able to sign off on the Title VI as we included in our RFP specs. So when you look at Life Services, we found them to be the lowest and most comprehensive bid. One of the improvements that we will have in the proposal is an introduction of video conferencing. We had included in the bid specifications that we would like to have some type of remote services available since we run 24/7 operations. Specifically, I used our sheriff's office as an example to individuals interested in quoting, and I explained to them that you may have a patrol officer that works second or third shift that would be glad to maybe get out of bed and throw on a hat and jump online and have a counseling session, but having to get up, brush their teeth, and drive across town may discourage them after working a second or third shift. And so we were able to include that in the bid specs, and Life Services was one of the companies that did deliver that solution to us. During the finalist interviews, Ms. Stevenson and I talked with Life Services, and we asked if they are the finalists, if they could expedite the implementation of that video conferencing capability, and they have agreed to do that and roll that out during the month of March. So that is one improvement over current contract that personally I think will be beneficial to our employee population and hopefully increase utilization of our clinics. The EAP location is open Monday through Friday from 8 a.m. to 6 p.m., and they can accommodate other special request appointments as they are made as well. One of the things, too, to highlight the video conferencing is that right now we have a specific provider each day of the week there from 8 to 6 at our designated location. But if someone calls in and they're an established person, because they have to have a face-to-face first before the video conferencing becomes available to them, there may be someone else that is employed at Life Services, that's one of their therapists, that may have an opening, but that is working out of their Franklin office on that particular day. They'll actually be able to place our employee in that video conferencing hour slot for that therapist who is at Franklin. So now we will have more capacity, because we could have someone in office in Murfreesboro and someone video conferencing with a different therapist at the same time. So I'm very excited about what this will do for some of our 24/7 operations and making that available. Same thing with our school teachers. You know, as long as they have a private location that they can go to, they'll be able to use their iPhones or anything like that, just as long as they have connectivity, so that they can have that counseling session. Employees can go out to their vehicle during lunch. I mean, I think it gives us more opportunity as an employer to make this available to our employees. Everything else that we currently have in place remains the same. I know that they provide a lot of support to human resources in terms of offering different programs that they need to come in. I know that they came to our leadership meeting not long ago and did a presentation at the request of Ms. Stevenson. So the recommendation to the committee is to award the contract to Life Services for the EAP bid. It is a 3-year rate guarantee at $1.38 PEPM.
Okay, so what's the wishes of the committee? Mr. Sandvik.
I'd like to move to approve I'd like to make a motion to approve the bid or the recommendation of Ms. Street. And I have a question in the discussion time.
We have a motion. Do we have a second? Ms. Allen and Mr. Hafner, et cetera. Now, Mr. Sandvik, you may ask your question.
Recall any details on the homework helpline?
Yes. The homework helpline is not something that we are recommending. It is something that was made available, and it basically covered the categories of social studies, history, math, and reading for K through 12, and they could call and speak to someone in that age, you know, that specific width, whatever that school age is, to help them if they get stumped on a math question or something like that. There is. It is 15 cents PEPM, if I recall. The school system, do they currently have something that they offer? No. Or don't participate, but we have in the past. Is that right? Okay, all right.
But this 138 does not include that?
No, it does not. That's an additional
service.
15 cents.
Ms. Street.
Oh, Mr. Nipper.
How successful was that program, the one for the school kids to call in?
The homework helpline?
Yes.
That's something that I'll defer to the Board of Education to respond to. Is that something you can respond to, Dr. Anthony or Mr. Sandvig?
Group that was sponsoring that in the mid-state area several years ago moved to a charge request, and we kind of phased out at that point.
No, if United Way offers anything in terms of homework helpline. I can't recall. Somebody has something. I'll see if I can, and I know Ms. Stevenson's good about recalling things like that as well. See if we can recall what we have ran across lately and share that back with you.
I can see this or some other option being something the board might be interested in if it's not too late to.
We could go ahead and approve the base EAP contract, and I'll be glad to share more information with you about this additional fee, and if you feel like it's something you'd like the committee to consider, then we could bring that back as a separate line item, because it's not, you know, awarding the contract is not contingent on that aspect of it.
And when would this be effective?
This particular contract would go in effect on June the 1st.
June the 1st of this year, okay.
Yes, sir.
So there would be a little bit more time to discuss that if we choose to.
Right.
Okay, so we got a motion and a second. Any other questions or discussion? All of you then in favor of this, please say aye. Aye. Any opposed? Thank you. Mrs. Street, upcoming bid announcements. I may have passed you over there.
That's okay. We will be releasing a bid for voluntary products, flexible spending account, and COBRA. Willis Towers Watson is leading the bid initiatives on that. The bid will be released in March and will be received by purchasing in April, and we will bring that back to committee once we've had an opportunity to review and determine finalists. So you can see that in the coming months. I just wanted to make the committee aware that we did have those products going out to bid.
And are those 3 separate bids, or how does that work?
So the voluntary products are all bid together. That's your critical illness and cancer products. And then flexible spending and COBRA typically goes out as one combined bid. Those are typically the same vendor.
Okay. All right, thank you. Now, give us an update on the dependent audit.
So we've just concluded the dependent audit as of February the 18th for the initial phase. We are now entering into the appeals process that will last till March the 18th. The report that you have been provided shows you the total number of employees that were sent notices of participation, which was 1,373. Those are the number that had spouses on the plan. Of those, we have to date 215 ineligible dependents identified. That number will continue to decline during the appeals process. However, if you'll look at the average annual cost per dependent, and that really dependent relates to spouse, because we were only doing an audit to determine spouse eligibility, specifically as it pertains to the working spouse and availability of group coverage through their employer. And the average annual cost per spouse on the insurance from a claims perspective is $6,688. When you look at the number of ineligible dependents that have been identified to date of 215, that gives a first-year projected savings of $1.4 million in claims cost. So I know there's been some discussion on social media and other sites about having to go through this process. I know it's a little painful for people to have to pull the information and send it in, and it's not something that's typically popular with employees, but you can see that when you're producing results over $1 million, and the cost for the audit is going to be $18,192. So we're going to spend $18,000 to realize over $1 million in claim savings. It is a worthwhile process for us to go through. So we appreciate their participation. I can tell you that I've been contacted by several employees. They've really been active in participating. I know Dr. Anthony's gotten several emails, and it's created more work for her, and I appreciate how she has forwarded that on to me to give me an opportunity to respond. But at the end of the day, we're a self-funded insurance plan. And every dollar that we incur from a claims perspective gets paid one way, through county contributions on premiums and contributions we make as employees. So we do these things that we've talked about today, from savings through Cigna, the on-site medical clinics, our wellness program, and these type of audits, so that we can all control what our premiums are on an annual basis. And so we appreciate the efforts of everyone and their participation in this particular audit.
Yeah. How long has it been since we did this dependent audit? Has it been a few years?
So we really do 2 processes. This particular type of audit, it's been 5 years, well, no, since 2011 was the last time that we finalized an audit. It had started in 2010, finalized at the beginning of 2011. Since then, what we have done internally in my department is Melissa Career is responsible for dependent verification. So every time someone adds a dependent to our insurance plan, they are responsible for providing documentation to confirm eligibility. To date, we have used the honest approach to spousal verification, and they would just, there would be a statement, an attestation, where when they enroll them, they, by clicking this, I am affirming that my spouse does not have group coverage, et cetera, et cetera. I can tell you at the very onset of this audit, within the first 2 weeks, we had about 13 employees step forward and call Hodges Mason, say, my spouse isn't eligible, go ahead and take us off. And we have now seen 200. Sometimes it's because they really don't understand exactly, whether or not their spouse is eligible, or they enroll them, their spouse changes jobs during the year, and they don't link it back to, hey, this changes their eligibility on insurance. So, every 5 years or so, it's important that we go through a cleanup process like this.
Okay. Any questions regarding that? Any other business anyone wishes to bring before this committee?
I would like to make one final comment about the dependent audit. One of the things that we did was we created an employer verification form that we utilized during the dependent audit. So anyone that had a spouse that works, they have to take that form to their employer and they have to fill out, we don't offer insurance or anything like that. We've not used that in our ongoing regular dependent verification process in my office, but we will be introducing that into our process as one of the required documentations whenever they add a spouse, is that they'll have to provide that employer form as well. So.
Okay, if I see no one else wishing to have anything to discuss, thank you very much, and we are adjourned.